Okay, I think I am okay. Okay. So, good evening, everyone. All respected doctors and all the speakers. All of you, welcome to today's our eyesight meeting. And in today's eyesight meeting, we have three prominent speakers. They are Dr. Rupak Roy from Kolkata, Dr. Mimamsa Agasti from Agartala, and Dr. Ghazal Patnaik from Odisha. So I would like to welcome all the speakers to our today's eyesight meeting. So let me introduce first our first one, Dr. Rupak Roy sir. Presently, Dr. Rupak Roy sir is working in Sankara Netralaya, Kolkata. So he's a very national international speaker. And he did his MBBS from Kolkata National Medical College and his MS from RIO West Bengal, Regional Institute of Ophthalmology, West Bengal. And after that, he did his fellowship from Sankara Netralaya, Chennai in 2010. Welcome, sir. So welcome to your today's our eyesight meeting. Our next speaker is Dr. Mimamsa Agasti, ma'am. Presently, Dr. Mimamsa Agasti is working in Surfside Eye Center, Agartala. She is working as a vitreoretina surgeon in Surfside Eye Center, Agartala. So Mimamsa ma'am did his MBBS from SCB Medical College and Hospital, Cuttack, Odisha. After that, she did her MS from Regional Institute of Ophthalmology and Motilal Nehru Medical College Hospital, Prayagraj, Uttar Pradesh. And she also did her fellowship from Arvind Eye Hospital, Pondicherry. Welcome, ma'am. Welcome to our today's eyesight meeting. Our third speaker is Dr. Ghazal Patnaik, ma'am. Dr. Ghazal Patnaik, presently she is working in the Hello, am I audible?
No, you are muted. Unmute
Okay. So our third speaker is Dr. Ghazal Patnaik. Presently, she is working in the Radharaman Eye Hospital, Cuttack, Odisha. Dr. Ghazal Patnaik, ma'am, did her MBBS from CG Medical College and Hospital, Behrampur, Odisha. And after that, she did her MS from Utkal University, Odisha. And also, she did her fellowship in UV and Medical Retina from Sankara Netralaya, Chennai, Tamil Nadu. So welcome, ma'am. Welcome all of you to today's our eyesight meeting. And our first topic is the diabetic macular edema from understanding to treatment. And speaker is Dr. Mimamsa Agasti. So I would like to come Dr. Mimamsa Agasti to present her presentation.
Hello everyone. I'll be sharing my slide now. So is my screen visible? Hello?
Yes, ma'am, yes, visible.
So I'll be starting my talk now. Hello everyone, I'm Dr. Mimamsa Agasti and I'll be discussing about the diabetic macular edema, the treatment and the understanding part. So a good evening to everyone and thank you for joining us. The screen is...
Please, full screen you can.
Yeah, it's not. The icon is not showing again. Tech team, can you make it full screen?
Ma'am, are you able to see the from beginning option on the slideshow at the top of the screen?
Yeah,
Top right,
setup slideshow
from beginning.
from beginning. Okay. Okay.
Yes.
Yeah. So thank you, Bayer Technologies, for giving me this opportunity to present this topic. So, so to understand diabetes, the global burden of diabetes is rising dramatically, which means the burden of diabetic retinopathy and diabetic macular edema will also continue to rise. So coming on to a few numbers. So key numbers are the global diabetes prevalence was around 463 million in 2019, which has been expected to project a rise of around 51% by 2045. That is up to 700 million. There'll be a global rise in diabetes, which means that the diabetic retinopathy and diabetic macular edema will also be on the rise. So regions which project the highest rise are Africa and Middle East and North Africa, which are projected to show a 143% increase of Africa, and Middle East is supposed to show 96% rise, that is up to 108 million by the year 2045. European countries and Western Pacific countries are supposed to show a lower percentage of rise, that is 15%. However, there is expected to be a global rise of 51% by 2045. So, what is diabetic macular edema? So, DME is the accumulation of excess fluid in the macula, which is due to leakage of retinal fluid from the damaged retinal blood vessels, which in turn results the macula to swell up and become edematous, which in turn will affect the visual function. The key role which is played by VEGF-A. VEGF-A increases the vascular permeability and it disrupts the blood-retinal barrier, which in turn leads to diabetic macular edema, leading to a moderate to severe visual loss in patients with diabetes, leading to blindness in the working age populations in most developed countries. So it can, diabetic macular edema can affect people with both type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 people, type 1 diabetes mellitus, 100% people show diabetic retinopathy, and type 2 diabetes, at least 90% people are supposed to show diabetic retinopathy. So, visual loss in patients who have diabetic macular edema can have life-changing consequences because most of these people are of working age. Typically, if you are working age, is a lifestyle disease, and people presenting with diabetic macular edema present difficulty with performing your near tasks like reading, using your mobiles, recognizing faces, doing your fine work. They have difficulty in reading, like there's a reduction in the daily functioning, reduced work efficiency, there is reduction in mobility, there is less independence, they have difficulty in perceiving colors, that is the contrast sensitivity and their visual acuity is affected. Such people tend to become depressed because of increased dependency on other people and of increased social isolation. So, because of the poor disease burden and reduced self-care, there is a higher chance of mortality in patients with diabetes and having diabetic macular edema. So, if left untreated, this diabetic macular edema can progressively damage the macula and cause severe irreversible visual loss. So, diabetic macular edema can occur in any stage of diabetic retinopathy, be it mild, be it moderate, severe, or even PDR. What happens? Poor glycemic control, untreated diabetic macular edema leads to severe visual impairment and blindness. So normally there is a well-organized retinal architecture which due to fluid accumulation between the retinal layers, there is retinal thickening, there is loss of the foveal architecture, there are microaneurysm formation, there are intraretinal hemorrhages, there are lipid exudates, there are succinate retinopathy, so retinal thickening occurs. Fluid accumulation can occur between your outer plexiform layer, between your inner nuclear layer, in your Henle's layer, or there might be diffuse retinal thickening involving multiple layers. And hard exudates typically deposit in the outer plexiform layer around the Henle's layer around the fovea. So coming on to a bit of history. So, the treatment of visual impairment due to diabetic macular edema has evolved over time. Initially, in the year 1985, ETDRS projected focal or grid laser to be the gold standard of treatment, which caused reduction of the risk of visual loss. It stabilized the vision, however, it did not improve the vision. So this happened in the era 1985 eras when the treatment for diabetic macular edema started over time. So gradually laser was the gold standard from 1985 up to the 2011 and 2012 when the RESTORE and the Rise and Ride trial showed that the anti-VEGF era began. And this marked the shift from preventing visual loss to actively improving the vision. So in 2011 and 2012, steroids entered the game via the FAME trial, which showed fluocinolone acetonide to be approved for DME, and then dexamethasone via the MEET trial approved for DME in 2014. The next also trial which happened in 2014 was your VIVID and your VISTA trial in European and American population, in which aflibercept as a strong molecule evolved for treatment of diabetic macular edema. Next, by 2022, the molecule called faricimab became approved in 2022, which blocked both VEGF and angiopoietin 2 and led to fewer injections. Currently, aflibercept as a 8 milligram molecule has been approved in 2023. It's been in use in 60 major countries in US. It has been approved in major populated areas like US, UK, Europe, Japan, Australia, etc. Yet to happen in India, of course, not yet approved in India for the 8 milligram. What factors drive the key mechanisms behind the pathogenesis of DME? So, VEGF-A and placental growth factor act via the VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. So, VEGF-A is VEGF-A and placental growth factor. So VEGF-A acts via VEGF receptor 1 and VEGF receptor 2 directly, and placental growth factor acts both directly via VEGFR1 and indirectly via VEGF receptor 2. So that promotes inflammation. VEGF receptor 1 promotes inflammation. It worsens the vascular instability. So there are heterodimers too of VEGF-A and placental growth factors, which can activate the VEGF-R1 and R2 complexes, and it further can enhance the endothelial activation, inflammation, leading to leakage. So excessive activation of VEGF-R1 and 2 can cause increase in leakage, edema, inflammation, and neovascularization. Here we see the pathophysiology of DME in this flow chart. So diabetic macular edema develops through a vicious cycle of ischemia, then inflammation, then vascular permeability and neovascularization. So what happens? Diabetes causes capillary damage. There is reduction in retinal blood flow. The microvasculature of the retina is damaged. The blood supply drops. The retina becomes hypoxic. And the hypoxic retina releases the VEGF and the placental growth factor, which in turn activate the VEGF-R1 and R2. So this triggers inflammation via the inflammatory cytokines, and there is immune cell recruitment, which causes inflammation and RP cell damage. So next is increase in the permeability of the vasculature, which is due to endothelial cell damage and apoptosis and pericyte loss. There is also loss of your tight junctions, opening of your tight junctions. So next is your the third pathway is your neovascularization due to severe ischemia, which leads to formation of new vessels. These vessels are very leaky, friable, they are poorly functional, and they can break anytime, causing hemorrhage and fibrosis. So, aflibercept has a broader ligand blockade compared to ranibizumab and brolucizumab. Ranibizumab and brolucizumab, they act only on VEGF-A, which is a main driver of vascular leakage, edema, and neovascularization. However, VEGF-B and placental growth factor can be blocked by aflibercept. This also contributes to, because placental growth factor contributes to inflammation, leukostasis, etc. So these block, since ranibizumab and brolucizumab block only VEGF-A, they can only prevent VEGF-A from binding the receptors, and the VEGF-B and the placental growth factor remains active. So some pathway, some inflammation, leakage, edema doesn't get corrected by ranibizumab and brolucizumab. So aflibercept is a VEGF trap. It binds VEGF-A, VEGF-B, placental growth factor, which are the key factors, key drivers behind the pathogenesis of DME. So there have been several sources of evidence which support our anti-VEGF choice for our patients. There have been randomized controlled trials. There have been real-world experiences. There are meta-analytic networks. There have been international guidelines. There are mode of actions, even our own experience via patient choices cases. So, what did the VIVID and VISTA trials show about the impact of aflibercept in DME? So, in VIVID and VISTA trials, meaningful gain of vision was achieved in patients who had a good vision, who received early treatment, who received intensive treatment with aflibercept. It led to significant visual improvement even after and happened rapidly after the first loading injection, that is first 5 doses. And most improvement occurred within the first 20 to 24 weeks, and then it remained stable for 1 year. In the VIVID trial, after 1 year, after injection 5 versus laser, there was a gain of plus 10 letters on the Snellen's chart, and in the VISTA trial, around 12.5 letters. And here, the aflibercept was given in 4 weekly and 8 weekly. So, around 8.7 injections were given and 12.2 for 8 weekly and 4 weekly. So injection burden was reasonable by the end of year 1, because the Q4 group received around 11 to 12 injections and the Q8 received around 8 to 9 injections in the VISTA trial. So the VIVID and VISTA trial, they demonstrated that aflibercept produced rapid and clinically meaningful vision gain in DME compared to the laser treatment. And laser treatment just stabilized the vision loss, and aflibercept improved the visual gain. The visual gains came fast and they stayed. So next was a comparison of the VIVID trial, the VISTA trial, and the Protocol T trial, one of the most meaningful trials, which showed clinically meaningful gains in vision for patients who received early and intensive treatment with aflibercept. Vision improvement started early as with the first injection, and patients who received more than 8 injections through the first year and maintained vision gains achieved during the initial loading phase. Across the three major studies, VIVID, VISTA, and Protocol T, on an average, most patients gained 10 letters on the ETDRS letters, and at week 52, aflibercept showed superiority to lasers in the VIVID VISTA trial and to other anti-VEGF agents in the Protocol T trial. So, what is your VIVID and VISTA trials in patients who had poor vision? What happens if we delay aflibercept and start with lasers first? So, what happened? Delayed initiation of aflibercept led to worse long-term visual outcomes. Even the patients in the laser group, they were shifted to aflibercept later, but they never caught up with the patients who had started with aflibercept in the earlier dose. In the VIVID and VISTA trial, in the blue one shows aflibercept every 4 weeks, and orange line shows aflibercept every 8 weeks, and gray was with the laser treatment. So at least improvement of 11.7 or 10.3 ETDRS letters was seen with when the aflibercept was started early, and when it was started with laser, and uh, aflibercept was started at the week 100, there was an improvement of hardly 1.6 letters. Similarly, with Vista trial, there was a gain of 10.5 letters when the treatment was started early. However, people on whom aflibercept was given up to week 100, there was improvement of 1.4 letters. So after week 100, patients in the laser arm who had worsened were given rescue aflibercept for Prorinata. So what do the meta-analysis and expert international guidelines recommend for the treatment of DME? So Cochrane studies were done. So Cochrane studies was including 24 studies with 6,007 patients with diabetic macular edema whose baseline vision was between 2020 and 2040. So the conclusion in this study was aflibercept showed better visual outcomes compared to ranibizumab and bevacizumab, especially with people who had worse baseline vision. There was a greater chance of meaningful visual improvement. That is, there was at least 30% more chances of gaining more than 3 lines with aflibercept compared to ranibizumab or bevacizumab at the first year, and not much significant serious systemic adverse events were noted between all the 3 anti-VEGFs at year 1 or year 2 of follow-up. So other meta-analysis also were done, which was also favorable for aflibercept as a favorable treatment for patients with DME. There was comparison of aflibercept for 8 weekly versus ranibizumab of 0.5 milligram PRN. Aflibercept showed superiority in the baseline improvement at 52 weeks, and superiority means there was 95% confidence interval, which is statistically significant. Also, aflibercept showed improvement in the retinal anatomy better compared. There was reduction in the CMT from the baseline, the central macular thickness from the baseline. Aflibercept, along with improving the vision, it also reduced the macular edema, the swelling, effectively within 12 months. So the next was the international guidelines and recommendations. They also suggest that aflibercept should be the drug of choice in patients who have visual acuity of 20/40 or worse, that is less than 69 ETDRS letters. So there have been a few guidelines. So first is the EURETINA guideline. The EURETINA guideline says that if the patient has a significant visual loss at presentation, that is 20/40 or worse, aflibercept gives a better visual improvement compared to bevacizumab and ranibizumab, because the edema in these patients are severe, the VEGF load is higher, the inflammation is higher. So aflibercept will block both all the VEGFs, the VEGF-A, the VEGF-B, the placental growth factor. So there is a broader suppression which leads to a stronger effect. So the takeaway is severe DME, poor visual acuity. So definitely choose aflibercept first. The Asian recommendations in 2018 stated the same. That is, a patient with worse visual activity, visual acuity worse than 6/12, it may result in a more rapid visual improvement compared to ranibizumab over first year. The Canada guidelines stated that so superiority of aflibercept in the group of participants who had worse baseline visual acuity. This was at year 2. The gain was 18 letters in aflibercept, 13 letters with bevacizumab, and 16 letters with ranibizumab. So aflibercept was better. The Germans are a more cautious side of people, so they evidenced that aflibercept may be better, but they never said that it was superior. So they said there's a possible difference in drug efficacy if compared to bevacizumab, at a visual acuity of less than 20 by 50. So, along with this, can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? So, those were trials, but when we come to real world picture, so data from the Moorfields Eye Hospital and also said the same efficacy of aflibercept in compared to patients with clinical practice. So the gray bar shows the baseline mean visual acuity, and the blue bar shows the acuity at month 12. So they divided them into three groups. That was poor baseline group, that is less than 69 ETDRS letters. So in this group, the visual acuity improved from 52 letters to 65.8 letters with a mean number of injection of 7.4, which was a significant improvement. That is 3 Snellen lines of improvement. So in the better baseline vision group, the vision was improving. The baseline vision was 75, which improved to 77.6. There was a gain of 2.6 letters with a minimum injection of 6.6. There was a small gain. The treatment didn't fail, but the patients were already maintaining a good vision. There was reduction in the edema and there was worsening. So in the total cohort, so 59.7 was the mean baseline and it improved to 69.6 with a minimum mean injection number of 6.9. So poor baseline visual acuity is a commonplace in up to 2 by 3rd patients in clinical practice. So this shows that Resumab group versus aflibercept group. So Resumab improved a baseline of 7.6 letters, whereas aflibercept there was an improvement of 10.6 letters. This was after 1 year of trial. So the next was the VIBIM study that showed how treat and extend with aflibercept performs in diabetic macular edema over a period of 2 years. In year 1, there was a change of ETDRS letters of 9.1 and in year 2 of 9.4. The goal was to maintain the vision and to reduce the number of injections and the reduction of hospital visits. So mean BCVA by year 1 was 61.6 and year 2 was 61.9. So there was an improvement during the first year and it remained stabilized through the second year, which meant that there was a good long-term control. That is 57% of patients on 12-week treatment intervals at the end of year 2. The mean number of injections in the first year from 8.5 came down to 3.9. So the next was your Hirano trial. The Hirano trial showed that treat and extend with aflibercept in diabetic macular edema over 2 years. So mean change of visual acuity from baseline to year 1 was 6.1 ETDRS letters, and by year 2 it was 11.4. So patients who completed the 2-year follow-up were at least 70% of patients. And from baseline to year 2, there was a rise in ETDRS letters from 60.5 to 66.6. That is 66.7% of patients were on 16 weekly treatment at the end of year 2. So the next was the JADE trial. The JADE study showed that evaluated aflibercept treat and extend for diabetic macular edema over a year. From the baseline of 58.3 by the end of the year was an improvement to 66.6 ETDRS letters, and the mean number of injections over the year was 7.7 only. The proportionate of patients who reached the disease stability at week 20 and could begin interval extension was at least 87%, and 51% of people presented with an anatomically dry retina at the end of week 52. So, to summarize, aflibercept can achieve meaningful visual gains in patients with diabetic macular edema, as demonstrated by the randomized controlled trials, the meta-analysis, the international guidelines, and recommendations suggest that aflibercept should be the drug of choice when we are treating patients with baseline visual acuity of 20 by 40 or worse. So patients with visual impairment due to DME, those particularly with less than 20 by 40 can achieve meaningful gains with aflibercept as compared with other anti-VEGF agents in the real world clinical practice. So thank you everyone.
Thank you, Mimamsa ma'am, for your wonderful presentation. Hope you were explained very well all the studies and what is diabetes and all the studies. And thank you
Thank you.
once again from my side. Is there any question? All the doctors can ask Dr. Mimamsa Agasti. He's here, so you can ask if you have any doubt. Or we can do one thing. We can after all the topic, we can go to the question and answer session. We can do that also. So right now, if there is no question, then I would like to welcome Dr. Ghazal Patnaik for our next topic. She will be presenting translating research into practice, real world application of DME management strategies.
I think some issues are there. Just
Tech team, are you there? Please help me, ma'am. Please help ma'am to solve our
I'm
issue.
not able to put on my video, not able to share also. I don't know what's happening.
Ma'am,
You are using the browser or app, ma'am?
Browser.
So that's the reason, ma'am. So
Oh,
I think tech team,
ma'am, you are not able to see the options, right? Below the screen.
no, I'm not able to put on the video also, not able to share. No option is coming up. Hmm.
1 second, ma'am, let me check.
Shall I rejoin? Yes. Oh.
ma'am, wait for a minute. So tech team will help you, ma'am.
No, okay, I could figure out something. Is my screen visible?
No, ma'am,
not
you are
visible yet.
not visible, ma'am.
It's okay.
So, ma'am,
Is it visible now?
Yes, ma'am.
yes, ma'am.
Slides visible?
No, slides are not visible.
You can click the share option.
Yeah, I did that.
You are in
Sharing. It's showing it. You are screen sharing. Then what? Right.
you are in iPad,
No, I'm in Mac.
MacBook. Okay.
So, Saurav, can I present till the time Ghazal figures it out?
Yes, sir. Yes, sir.
Yes, sir, definitely.
Yes, sir.
Yeah, sir. Sure,
Yeah.
sir.
So,
Yeah,
Ma'am,
Ghazal, is that okay?
See, sure, sir. Sure, sir. Please go ahead.
Yeah,
Ma'am,
that
please,
way you will also try to figure it out and we will be able to save time, है ना?
Yeah, sure,
ma'am,
sure.
मैम आप प्लीज एप्लीकेशन डाउनलोड कर लीजिए.
हाँ, yeah, correct. Okay.
हाँ, आप एप्लीकेशन डाउनलोड कर लीजिए इसमें.
So I would like to welcome Dr. Rupak Roy for our third presentation. He is HOD of Retina Department, Shankara Nethralaya, Kolkata. Sir, topic is evaluating the need for sense, evidence and insight on anti-VEGF therapies.
Yeah, is my presentation seen?
Yes, sir. Yes, sir. It's visible, sir.
Just give me 1 second. Yeah, so thank you very much for this kind invitation. So I'll be speaking about, I will basically be speaking about evaluating the need for changing evidence and insights on anti-VEGF therapies. As you all know, as Dr. Mimamsa has also pointed out, anti-VEGF therapy has sort of revolutionized the way the retina practice has evolved and how we treat our patients. In fact, we all know anti-VEGF treatment is probably the most commonly performed procedure in medicine, if you would consider across all the disciplines. So we all know the current anti-VEGF treatment of choice is bevacizumab, which is not really available in many parts of India. Then we have innovator ranibizumab, then we have aflibercept, and briefly we had brolucizumab, but we all have sort of shifted away from it. And of course, we have the new kid on the block, that is faricimab. So, what are the challenges? The basic challenge in anti-VEGF treatment with NMD, in my mind, is three. One is that there are a lot of individual differences in the response to an anti-VEGF agent, and the availability of multiple anti-VEGF agents with different molecular configurations. This is the basic challenge that a clinician usually faces in the clinic when deciding on an anti-VEGF. On the other end of the spectrum, if you think of from the patient's perspective, they will probably think it as the cost involved with it, the cost involved with it, the multiple nature of the injections and multiple clinic visits. But to me, the most important criteria when one chooses an anti-VEGF agent is efficacy, that it should be efficacious. That is one most important point. And the second thing is durability. We all started treatment with ranibizumab, where we had seen the treatment usually typically lasted for a month's time. And then we progressively shifted to newer generation molecules like aflibercept, which had longer duration. And finally, I feel the most important part is the safety part of it, that the drug should not harm the patient. So how do you define response to anti-VEGF? It could be a primary response that we usually see 1 month following the last loading dose, and a secondary response anytime after the fourth visit. And of course, there is a ceiling effect that can negate the currently used functional matrix. Okay. In Indian situation, PCV is a very important subtype of NMD, and ICG is invaluable for those situations. So how really should we define the response in anti-VEGF? It is good if there is absence of subretinal fluid, intraretinal fluid or cyst, or a reduction of central retinal thickness greater than 75% of the baseline values. And if you look at the functional, if the improvement in vision is more than 5 letters from baseline. Partial, we can call if the reduction of CRT is between 25 and 75% of the baseline values, and persistence of SRF and ARF, and change in visual acuity 1 to 5 letters from the baseline. If it is poor, if there's only 0 to 25% reduction, and very less reduction gain in the visual acuity. But is non-response unchanging or increasing CRT in spite of treatment, increasing SRF, IRF, and drop in vision even on treatment. So what about switching to a newer anti-VEGF agents? So faricimab has been extensively used throughout the world and has been used as a switch agent. So there are multiple studies by groups like Mukai et al. And Turkey et al. And also we have studies from Moorfields and the Far Retina groups. So if you see when they were switched, when they're switched from aflibercept, there was a very modest gain in visual acuity, and the difference was not significant. In fact, in the Moorfields group, when there was switching from aflibercept, there was actually loss in vision. So that is the reason probably why that aflibercept is the prescribed injection for Moorfields. They have not yet shifted to. So Moorfields is part of NHS. So if a patient is walking into NHS with an AMD, the treatment of choice is aflibercept till date. They have not shifted their this thing. So 92% of patients we switched from aflibercept to faricimab discontinued treatment due to insufficient efficacy. This has been proved in studies. So this is a study by Kotaoka et al., where they have found that around 60% of patients actually discontinued faricimab treatment due to lack of insufficient efficacy, and 73% actually did switch back to aflibercept. One of the major changes that had been highlighted with faricimab is that ability to extend more than 4 months, that is 16 weeks. But in real life clinical experience, we have seen that it is really difficult, even with agents like faricimab, to extend beyond 3 months. So, and even studies like this have showed that majority of the patients could not be actually extended beyond Q8, that is 2 months. So 71% of patients we switched from aflibercept to faricimab remained on less than cuvette intervals. So the perceived promise of faricimab was this unique ability of it to achieve the extension phase. When the patient is on a treat and extend regimen, you start the patient with the treatment of loading dose, and then slowly you put the patient on a TREX regimen. And the idea of faricimab was to able to extend it more than 16 weeks. That is Q16 or 4 months. But real life studies have shown that less than actually 71% of patients actually were not able to, clinicians were not able to extend them more than 8 weeks. So after 3 loading doses, significantly better visual outcomes were observed with aflibercept compared with faricimab. This was noted with in the study by Hera et al. And here they have compared aflibercept 2 mg versus faricimab 6 mg. So again, there is a real world study from the UK which showed 6 months of real world study with faricimab in DME have shown limited vision gains. You can see after the 3rd injection, there is a rise in the vision, but ultimately it drops down after the 4th injection. So if you look at the injection sequence, 86 of the patients are switched from the aflibercept. Despite multiple faricimab injections, majority of the patients are in Q8 intervals, which is Q8 or Q10 is typically the interval that we are able to achieve with aflibercept consistently. But in faricimab, studies have shown it has not been achieved very consistently. So several different approaches have been attempted in an effort to improve patient outcomes. So the primary thought process is that VEGF is the primary target, but do we need to target other pathways or other molecules which have role in increasing the vascular permeability, vascular leakage, accumulation of fluid, and the retinal inflammation? So what are the additional pathways? They could be Ang2, they could be PIJ, GAL1. So if you look at additional pathways, we can look into aflibercept 2 mg with a combination of nesvasumab. If you see faricimab, it is taking care of the Ang2 pathway. If you look at brolucizumab, that's the basic concept was increasing the molar dose and the small antibody fragments, so there is more penetration of the drug. And of course, the surgical implantation of the port delivery of ranibizumab that was hyped, but it did not go through the clinical trials and did not really come into clinical practice. So if you look at this combination, in the Ruby and Onyx actually targeted both Ang2 and VEGFR pathways and did not provide additional improvements in vision. So this has been a common thought process that just by blocking Ang2, you are not going to get anywhere with efficacy in this spectrum of diseases like ANMD and DME. So if you look at faricimab, we have talked about faricimab, that the faricimab trials had non-inferior visual outcomes as compared to aflibercept. That's why probably faricimab did not gain the agent of choice in various drug control trials. So Avenue clinical study is where ranibizumab and faricimab achieved similar levels of plasma Ang2 inhibition after 1 injection. So this study basically proves that even with the currently available anti-VEGF agents, the Ang2 inhibition is obviously there. So you don't really need an agent which we can actually say that they can combine the efficacy against both the agents. So faricimab failed to meet the primary endpoint of superiority to ranibizumab, and levels of Ang2 inhibition were similar between agents. This is an important study because the whole argument around the faricimab molecule is that it blocks the VEGF and it also blocks the Ang2. So this study actually showed us that Ang2 inhibition was also available with ranibizumab, and so faricimab was really not adding anything new. So the VEGF binding arm of faricimab is ranibizumab, and role of Ang2 has not yet been established to show clinical effectiveness. So this has been shown in multiple trials also, where faricimab has consistently non-inferior efficacy to aflibercept. So the FDA have stated the VEGF antigen binding fragment FAB is identical to ranibizumab, and the contribution of Ang2 inhibition to the treatment effect and clinical response for ANMD and DME has yet to be established. So preclinical data suggests that VEGF is a key driver of angiotensin production, and anti-VEGF agents can block VEGFR-driven Ang2 generation. So what it means is basically Ang2 is upregulated by the VEGF only. So if you are able to achieve consistent and profound VEGF suppression, it will automatically suppress your Ang2. So aflibercept showed the most durable effect in blocking the effect of human VEGF on Ang2 levels in this preclinical rabbit models. So basically to summarize this presentation, what it means that the VEGF still is the predominant mediator, which is causing the diseases like DME and NMD. Yes, there are other mediators like you can say IL-6, ILCP, Ang2, GAL, PIGF. So there are two problems with the other mediators that multiple studies have shown that VEGF is the consistent mediator which causes upregulation, and this in fact causes edema. There are other mediators who have a role in this inflammatory cascade, where there is accumulation of fluid. But there are two problems. One is we don't have reliable agents which consistently block the other mediators. And second is that the second is the role of the other mediators vis-a-vis VEGF is, so far our knowledge, is not so great. So we should always target the VEGF. So the VEGF pathway is the master regulator of pathological angiogenesis. It comprises of VEGF1 and VEGFR2. So aflibercept is the only widely approved agent that blocks all VEGFR ligands and the key VEGFR2 ligands. So aflibercept actually targets VEGF and also targets the key ligand PIGF. So to summarize, with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Increasing the molar dose of an anti-VEGF agent may have the potential to offer patients more thorough extended VEGF suppression. So have we maximized outcomes for our patients, or can we go further? So aflibercept 2 mg is actually the benchmark molecule. It is safe, it is durable, it is efficacious. It targets the VEGF and the key ligands. So the data from the next step, of course, is the aflibercept 8 milligrams, which is not yet available in India. So data from PULSAR and PHOTON suggests that aflibercept 8 mg has potential for greater and longer lasting control of the underlying disease compared with aflibercept 2 milligram to sustained disease control. So this is the end of my presentation, which puts a case that VEGF is the primary molecule, and so far our clinical experience and experimental data shows that aflibercept is the most efficacious agent. And obviously we know that aflibercept 8 milligram has come in US and it has shown considerable promise. Hopefully it will come to India and we'll be able to use in our patients and benefit the patients. Thank you very much for all your kind attention.
Thank you, Rupok sir, for your wonderful presentation. You explained all the things. You explained beautifully, explained the aflibercept versus faricimab. If any question, please ask to Dr. Rupok sir. He is here to answer all that.
Dhruvada, meanwhile, the Ghazal ma'am presentation is still left. So can we complete that? And at last, if there is any question answer is there, you can ask.
Okay. So I would like to welcome Dr. Ghazal Patnaik ma'am. So ma'am, please come. Ma'am, are you there?
Yeah, I'm trying to share.
Okay.
My slides visible?
Yes,
Yeah,
ma'am.
yeah.
It's
It's
perfect.
visible.
Visible.
Shall I start?
Yes, ma'am. Yes, you can.
Okay, thank you so much. Good evening, everyone, and sorry for the technical glitches. I'll try to wrap up as early as possible.
Ma'am, sorry to interrupt you. Please switch on your video, ma'am.
I'm not able to do that simultaneously. I joined from two sites, but not one second.
Okay, ma'am.
Okay, no problem, ma'am. You can present.
Can-
Okay, ma'am. You can continue, ma'am.
I'll change the. So thank you for the opportunity. We are going to speak on a topic that we encounter almost every day in our retina practice, that is diabetic macular edema. And more importantly, how do we translate these evidences from clinical trials? I thank my previous speakers for covering exhaustively the landmark trials. How do we translate these trials into meaningful outcomes for our day-to-day patients sitting in front of us? Over the years, we have accumulated robust evidence ranging from pivotal randomized control trials to long-term real-world registries. Today, I would like to briefly walk you through this growing evidences that can help us, that can guide us for our day-to-day clinical decisions. However, there are various limitations of the clinical trial designs. The randomized control trials, they remain the gold standard for establishing the efficacy, as we all know. However, their patient populations are highly selected and often quite different from those that we encounter on routine practice. In real world, our patients bring with them multiple systemic comorbidities, irregular follow-up, travel constraints, financial limitations, and moreover, variable glycemic control and compliances to the treatment. Particularly in our setting, delayed presentation and poor baseline vision are far more common than what we see in these clinical trials. In addition, there is no universal consensus regarding the ideal treatment regimen, that is either monthly injections or PRN or treat and extend, all of which involve their own balance between the efficacy and the treatment burden. This is precisely where real world evidence becomes indispensable. It does not replace randomized control trial, but it does complements them. So the current anti-VEGF landscape in DME, we have multiple anti-VEGF agents like ranibizumab, bevacizumab, aflibercept, and recently faricimab and brolucizumab. Large landmark studies have established anti-VEGF therapy as the first line treatment for diabetic macular edema. However, in our routine practice, the challenge is not merely choosing an anti-VEGF agent. The real challenge lies in achieving long-term visual outcome while minimizing the treatment burden and ensuring patient adherence. So as we have understood these trials earlier, I would just highlight few important points. Most of us are familiar with this Vivid Vista and Protocol T trials. They demonstrated sustained visual gains over 3 years with aflibercept, mean best corrected visual acuity gain of over 10 ETDRS letters at 3 years. Protocol T subsequently provided a head-to-head comparison with ranibizumab and bevacizumab. Perhaps the most clinically relevant observation from Protocol T was that the patients presenting with a poorer visual acuity baseline, that is below 69 or 6/9 ETDRS letters, appeared to derive greater benefit from aflibercept during the first year. In Protocol T subgroup, the worst baseline vision, the aflibercept gains reached around 18.1 letters at year 2 versus 13.3 letters with bevacizumab and 16.1 with ranibizumab. This finding has subsequently influenced the recommendations and clinical practice patterns across multiple regions. So why do we need this real world evidences? Why this RWE matters? The RWE complements the randomized trials by reflecting the complexities of routine clinical practice, as we discussed earlier. How treatments perform outside the tightly controlled studied settings, the impact of treatment burden on long-term outcomes, the durability of response beyond trial follow-up periods, the country-specific treatment especially, and ultimately the practical value of our treatment choices. So the real world evidence therefore bridges the gap between the efficacy and the effectiveness. This is shown by long-term durability study, that is endurance study. They extended the VISTA experience to 5 years. The reassuring message here is that the visual gains achieved during the earlier years were maintained over the long term, while the treatment burden progressively decreased. This highlights the important concept that early intensive treatment can allow later de-escalation while maintaining visual outcome. Similar real-world outcomes were given by the Apollon and the Moorfield studies. These are real-world studies that address the important question that do the outcomes that are observed in randomized control trial hold up in everyday practice? Apollon, they found out that treatment-naive patients achieved a gain of 6.5 weekly DRS letters at 24 months as compared to a gain of 9.4 that was shown in Vivid study. The key differentiator was 52% of treatment-naive patients received all 5 initial monthly loading doses. Moorfield simultaneously found that the mean gain was 6.9 letters at year 1 and 13.8 letters in the subgroup of patients who had baseline base-corrected visual acuity worse than 2040, which was 58% of the cohort. So the difference between trial outcomes and the real world outcome is often driven more by the adherence to early intensive treatment than by the treatment itself. Then across multiple data sets like Draco, Moorfield's, FRB registry, the one observation that remarkably is consistent is that the nearly 2/3 of patients they present with a baseline base-corrected visual acuity of less than 69 ETDRS letters. This has also been reproduced around all other real-world registries, like the Moorfields. I'm not going into the details because this has been extensively covered earlier. Similar studies have been found from India as well, where they also found that both groups improved equally. They compared DEX and they compared intravitreal aflibercept. However, aflibercept had a 6.5 more likelihood of improvement. So they concluded that both intravitreal aflibercept and DEX provide similar visual and central macular thickness improvement in recalcitrant DMEs. Intravitreal aflibercept, they lead to more than 3-line visual gain, but require more injections and follow-ups. Similar guidelines were given by our All India Ophthalmic Society Diabetic Retina Task Force and the Vitreoretinal Society. They also found that the anti-VEGF therapy is more effective in improving the vision as compared to the macular laser treatment. So international guidelines also support this evidence that the EURETINA and the Canada, Diabetes Canada, the German Ophthalmological Society, all of them, they support the preferential use of aflibercept in patients presenting with poorer baseline vision. Cochrane meta-analysis of 24 randomized controlled trials, over 6,000 patients were more than around 30% more likely to gain 3 or more lines with aflibercept at 1 year. For every 1,000 patients, switching to ranibizumab would mean 92 fewer achieving a meaningful visual gain. Also, when making an evidence-based decision, we rely on the highest level of evidence, that is by the randomized control trial, meta-analysis, and then the real-world registries. Aflibercept continues to serve as an active comparator in multiple DRCR retina network protocols, reflecting its status as the benchmark against which newer agents continue to be evaluated. So to summarize the evidence, real-world outcomes are broadly consistent with RCT data when early treatment intensity is maintained, baseline visual acuity is the key differentiator, and the majority of real world patients fall in this subgroup, and that this benefits the most. Long-term treatment burden can be reduced without compromising vision gains. Several international recommendations, as we saw now, support the preferential use of aflibercept in patients presenting with poorer baseline vision. So far, we have discussed what clinical trials and the registries tell us. But ultimately, we do not treat these studies, we treat the patients, right? And often our patients do not read the protocol T or the Draco study or anything. They present late, they miss the appointments, they have systemic comorbidities, and they may arrive with visual acuity far worse than 2040. With that in mind, I would like to share 4 cases from my practice that illustrate how these principles that we just discussed translate into real patient care. The first one is very common, very nice. That is a treatment-naive DME patient with a poor baseline vision. 58-year-old man, type 2 diabetes for 15 years, best corrected visual acuity 624, HbA1c is 9.2. The OCT shows central involving diabetic macular edema. So this fits to the RCT trials, all the trials we discussed. So the poor presenting vision, the center involving DME, cystic changes, intravitreal aflibercept was given in a monthly dosage. And after 3 monthly injections, best corrected visual acuity improved to 612. The patient was phakic with cataractous changes. There was complete resolution of the edema. So this case highlights the protocol T message that the patient presenting with poorer baseline visual acuity often derive substantial visual benefit with timely initiation of aflibercept. Now coming to case 2, this was a second patient, which is a 64-year-old lady, long-standing diabetes, referred to us after having 6 consecutive ranibizumab at another center for center involving DME. The visual acuity when she came to us was 618, and the HbA1c we found was 7.8. So despite 6 monthly injections of ranibizumab, there is persistent intraretinal fluid with increased central retinal thickness. The cystoid spaces remain prominent, and this is usually an OCT appearance of an inadequate responder, that is the anatomical persistence despite adequate treatment duration. So considering this persistent edema, after an adequate ranibizumab, a decision was made to switch the agent to aflibercept, because as we discussed, aflibercept also takes care of the collateral pathways, that is anti-PLGF activity. And then when we gave the patient 3 monthly intervals of aflibercept, visual acuity improved to 6.6, and there was a marked reduction of retinal thickness as well as the cystic changes. So persistent edema following an adequate anti-VEGF trial should prompt reassessment of the treatment strategy rather than continuation of an effective regimen. The lesson from this case is that there should be an individualized management rather than continuing an ineffective regimen indefinitely. Coming to the case 3, this is of a 67-year-old pseudophakic gentleman presented to us with recurrent diabetic macular edema despite intermittent previous treatment. So the best corrected visual acuity was 618 at this moment. Intraocular pressures were normal. There was persistent central involving edema with multiple intraretinal cystoid changes. At this stage, 2 treatment options were considered, like the intravitreal aflibercept or a steroid implant, DEX implant. The pseudophakic status is clinically relevant. However, the patient had a history of ocular hypertension in the fellow eye. So there was a concern of steroid-related IOP elevation. So after a thorough discussion, we covered the injection frequency, the need for monitoring requirements, steroid-related adverse effects. The patient opted to proceed with anti-VEGF therapy. So aflibercept was initiated. After the 3 loading doses, the patient improved from 618 to 69. There was again a drastic reduction in the macular edema. So here the key message was evidence should always be integrated with individual clinical circumstances. It is not about which treatment is superior in a trial. It is all about which treatment is most appropriate for this patient today. Coming to my last case, this patient is perhaps the most familiar to all of us practicing. It's a first 55-year-old lady with type 2 diabetes, having central evolving diabetic macular edema. 2 years ago, another center, she received 3 ranibizumab injections, showed initial improvement, but then she lost to follow-up for around 18 months. She again gave the same excuses that travel distance, financial constraints, family responsibilities. Now she came back to us with an HbA1c of 10.4. The base corrected visual acuity at this time was 636, which is significantly worse than when she was first treated. As you can see in this scan, there is a severe central involving diabetic macular edema with large confluent intraretinal cyst and marked disruption of outer retinal layers. The ellipsoid zone irregularity, the presence of drill, that is disorganization of inner retinal layers, subretinal fluid component is also visible. These structural changes are very important and they suggest that the potential for visual recovery may be limited as we saw in other cases. So the same discussion was made with the patient and her family, and the importance of regular follow-up was discussed. Systemic referral was made for her glycemic control and intravitreal aflibercept was initiated. After 5 injections of aflibercept, visual acuity changed from 636 to 624 only. The OCT although showed a reduction in central macular thickness, but the ellipsoid zone disruption and there was a structural damage from chronic edema. So this case highlights the reality we encounter regularly in clinical practice. The 18-month gap was the culprit that resulted in structural retinal damage, the drill present. This is the real world problem with the DME patients in our settings. So all the 4 cases taken together, they illustrate the full spectrum. The treatment-naive patients who respond beautifully when we get the drug choice, the loading phase right. The inadequate responder who needs us to reassess and switch rather than persist with an ineffective regimen. Third case, the recalcitrant case demands individualized decision-making beyond a one-size-fit. And the patient who was lost reminds us the importance of adherence, the follow-up as important as any pharmacological choice we make. So while the randomized trials provide the scientific foundation, successful DME management depends on translation of this evidence into individualized patient care. So early diagnosis, appropriate treatment selection, adherence to loading phase, sustained follow-up is actually important. So the research should not remain confined to publications only. Its true value lies in improving the vision, the quality of life patients we treat. Thank you.
Thank you, Ghazal ma'am, for your wonderful presentation, and you will explain the benefit of Eylea over ranibizumab. Thank you once again from my side. Is there any question to Dr. Ghazal Patnaik ma'am? And Rupokarai sir is also here. So, ma'am, Ghazal ma'am, you can, if you have any doubt, you can ask to Dr. Rupokarai sir also. So he's a very senior ear surgeon. So you can answer all the questions.
So I have a question for both Dr. Ghazal and Dr. Mimamsa. Say when you, I'm curious and I just want to know that whenever you see a patient, say for example of neovascular AMD, when they walk into your clinic, I mean, what are the things that when you decide I will give advice of this injection, what are the things that keeps moving in your mind? I mean, how do you come to a decision quickly in a clinical situation in the OPD where you don't have much time? So seeing a patient, say for example, a treatment naive patient or a resistant patient, and if affordability is not a problem, maybe both Dr. Mimamsa and Dr. Ghazal can share their experience and their ideas for all the audience.
If I could make a quick response to that, when a patient of either neovascular or DME patient comes, I first see the history, like treatment naive or any injections they have taken. The systemic things also I take into consideration, and I discussed thoroughly that systemic parameters also need to be checked, which I highlighted in all my clinical cases. Third thing, I see the OCT. OCT is very important to me, the structural changes, the biomarkers that are present. And in neovascular thing, I see the OCT angio. So if there is activity and the baseline visual acuity and the intraocular pressure, all this combined helps me to analyze if what could be the preferred choice of anti-VEGF or any other treatment.
Yeah, that is a good point. So, when do you, Ghazal, you have also good experience in inflammatory CNVMs.
Yeah.
Can you share what kind of anti-VEGF would you prefer, and how has been your experience with aflibercept in non-AMD like inflammatory myopic CNVMs?
Okay, so myopic CNVMs I think are the best. They respond very nicely with like 1-2 injections maybe. Coming to the inflammatory CNVMs, basically in that cases, I don't thoroughly rely upon OCT angio alone. I need to check whether it is a bilateral situation, whether it is a pan inflammation. So I do get an FFA done for those patients. And then if required, I go for like mostly steroids and aflibercept very rarely, but yes. So inflammatory are mostly systemic, and so systemic control of inflammation is important. And then depending upon the laterality, whether it is unilateral or bilateral, if it is unilateral, then yes, DEX implant or a PST would help. But if it is an bilateral case, then systemic treatment are my mainstay. And then depending upon the angiographic findings, we'll go ahead with the treatment.
Yes, sir. I'd like to say the same, sir. I also rely on the FFA and the OCT, sir. But I have stopped giving DEX implants since a long time, if cost is not an issue, because mostly the sarcophagus of the DEX implant keeps on roaming. I've seen 3-4 implant sarcophagus roaming around in the vitreous. The patient complains. So I have somehow stopped steroid implants and have started switching to aflibercept, because the results are tremendously very marvelous. Better of the OCT starts getting better, the vision starts getting improving. So if cost is not an issue, I've started shifting to aflibercept. I've also given Pegenex in many patients. The results are really good of Pegenex also. If there is less intraocular inflammation, if we avoid that thing, so the results of Pegenex are also good. So I usually rotate between aflibercept and brolucizumab if cost is not an issue.
So I am curious in cases of chronic DME also, you are satisfied with the results with anti-VEGF, right? So you are
Yes.
not doing also.
Yes, if cost is not an issue, if the patient can afford, I've shifted to anti-VEGFs compared to DEX implants.
So what are your take on this?
How long are you able to extend your patients in? I mean, what is your like treatment regimen in cases of a neovascular AMD? Like, say after the loading dose is over, how do you? What is your optimum protocol?
Sir, I usually go for the next OCT and I see what the next OCT is. If there is still fluid or heme, so I definitely inject. And if it has subsided, I go for 3 monthly OCT and repeat recheckups. So if the fluid reappears at any time or any minimal fluid or anything is there, I inject, sir. Because one cataract case had dry, like some few drusen only. The OCT was absolutely fabulous. There was nothing except a few drusen lying here and there, parafoveal region. But once we did the cataract surgery, the patient developed wet ARMD. There was fluid in the 6 monthly follow-up. So I do an OCT every 3 to 6 monthly in such kind of patients who are prone to developing
Okay.
fluid.
Yeah, that is a good practice. That is a good practice. Yeah, I think sort of any other questions are there?
Sir, I would like to ask you one thing. Like, how do you do a treat and extend for neovascular AMD for PCV without subretinal fluid, for PCV with subretinal fluid, and the recalcitrant DME and the cystic changes that we see for chronic DME patients? So how do you manage these five treatments?
Yeah. So basically for neovascular AMD, which is a treatment naive, the patient is coming to me. I will give 3 injections, 3 loading dose, and then 4th month I will give one more injection, and then I will call the patient after 6 weeks. Then again after 6 weeks I will inject the patient, and then I will call after 2 months. Then if the patient is okay after 2 months, at that visit also I will inject the patient, and then maybe call after 2.5 months and try to extend up to 3 months. And if the patient is stable at 3 months, I will inject every 3 months and start calling the patient every 3 months. And in between, if the patient has a recurrence, if it is if a recurrence is like the lot of hemorrhage and lot of fluid, I will give the patient a loading dose again. But if there is only small amount of fluid, maybe I will just give one more injection immediately and then again go back to the treat and extend regimen. So this is for neovascular AMD, which is treatment naive. For PCV, you told very correctly two situations with SRF, or without SRF and heme without heme. But I think PCV management is different from NAMD in the sense that the ICG plays a lot of role in PCV. And I'm very pro ICG. I'll do a lot of ICGs in PCV. And once the heme has resolved, I will do a ICG to look for any extrafoveal polyps. So if there are extrafoveal polyps, I will laser those patients, and then I will. So basically, for PCV also, I will go back to the treat and extend regimen. Diabetic macular edema, there are a lot of people who have done treat and extend regimen. I don't have any personal experience in this. Diabetic macular edema, I still do a PRN regimen. I don't have much experience with treat and extend in DM.
Okay, so as you said, like for neovascular AMD, even if the OCT shows a complete resolution of fluid, you still go with the injection at the intervals you just cited, or you wait for the fluid or the heme to come up? So should I repeat my query?
Yeah, you are not able to listen to me, right?
Yeah, so for neovascular AMD, you said that every 4 monthly, then fourth injection you will give, and then 6 weekly, and then 2 monthly and all. But if the OCT shows a complete dry macula, then also do you inject, or
Yes,
there
yes, yes,
is
yes.
no heme, no
Yeah, yeah.
fluid?
No, no, no. I will inject. If the OCT is completely dry, every 3 months I will inject. I will keep on injecting the patient.
So
So
what
whenever
are
this
the
patient
risk
is
of
coming to me,
developing? What are the risk of developing geographical atrophy in those patients for?
so yeah, what happens is, Ghazal, what I do is whenever I start treatment with patients, I will tell them that they will need every year 3 to 4 injections. And of course, we are guiding our treatment with OCT. If on OCT you see there is progressive thinning of the retina, of course you stop. And at that point, I will, if I suspect there is some thinning or atrophy happening, then I will do a FF to see better. But otherwise, I will keep on injecting the patient, because sometimes you know what, this patients will come back with a huge hemorrhage. And then, say for example, a patient was continuing on 6/9, and then suddenly the patient will go back to 6/6. It has really happened with a lot of my patients, actually. So you feel bad.
Frankly,
So
recently
atrophy
one
is
patient came.
definitely,
So he studied somewhere and he said that because you injected, that's why I developed this atrophy. So I just wanted to like
yeah, no, no. So atrophy is of course a risk factor, but the benefits of injecting is more than developing it. The standard of care is treat and extend, and people just keep on getting injections, because people who are very avid readers, they know that whenever they have a recurrence, they will come, and they know the uh, obviously, if the patient has financial constraint, the management becomes entirely difficult. But some patients who have good medical coverage, all those things, they can straight away know that this treatment is beneficial. But yes, see, atrophy is of course is a long-term side effect of prolonged anti-VEGF therapy. But not treating the patient, the risk of losing vision is more.
Thank you, sir. Thank you so much for the insights and the pulse. Thank you, sir.
Thank you. Thanks a lot. Thanks a lot. Saurav?
Yes, sir.
Yeah,
So,
if no more questions, then we can wrap it up.
yeah, definitely. So, final closing remarks, Dhruvoda, you can give.
Thank you, Rupak sir. Thank you, Mimamsa ma'am, and thank you, Ghazal ma'am, for your wonderful presentation. And all of you three well explained the benefit of Eylea over ranibizumab and other faricimab also. And from my side, thank you once again, and good
Thank
night.
you once again, all of our speakers. And it's a very interactive session today. And we are always looking for this type of opportunity in coming futures also. Thank you, Ghazal ma'am. Thank you, Rupak sir. And thank you, Mimisha ma'am. Good night,
Yeah,
everyone.
good night. Good night. All.
Thank you, sir. Thank you. Thank you.
Thank you, Ghazal. Thank you.
Good night. Good night, everyone.
Thank you. Thank you.
Yeah, tech team, you can compile now.
Okay, sir, we are ending the session now.
Yeah.